moving to next talk. I think there is a change in total change in program. Dr. Sivleen will be presenting first, and as Professor Usha couldn't come for today's program, and Dr. Pankaj Gupta will be presenting her talk. So I now request Dr. Sivleen to kindly start his talk.
A very good afternoon to all of you. I know 10 minutes is not enough to teach a topic like Srabismus, but Dr. Parul and Dr. Suresh gave me this topic of Srabismus cheat sheet. So I thought I'll just play with the words cheat, and that's how I am going to make you remember that few things that you have to remember when you are doing a Srabismus workup. Thank you, sir and ma'am, for inviting me here. So we'll just use these 5 words cheat, and I'll tell you 5 things that you have to do in a patient who's presenting to you with strabismus. So I'll just change the order a little bit, and I'll start with history and the head poster. So it's going to be a running talk. I hope you gather something out of it. So history, as all the talks that you have listened maybe today, always people will talk about how you have to take an adequate history and ask the patient as to when the onset of strabismus was, because that will give you a clue whether it's a congenital or an acquired condition. Often you'll see parents of children coming to you, and they'll not give a proper history. They'll just say that they noticed it a day before or a week before. So it is then that you have to observe for the head poster. That will be noticeable when the child is just walking to you, or the patient is just sitting on the examining chair, or maybe reading the Snellen's chart. So once the patient, like this one that you see, is using, so this patient is looking at the Snellen's, and you can see that he has a chin up posture, and you're not sure of this patient. She's taking a face turn or maybe a head tilt, and then you review the old photographs in these cases, and you see that yes, the patient was in fact taking the same head tilt and the face turn, and you establish that it was a congenital condition. Now, head posture is adopted often to compensate for the strabismus and the diplopia occurring as a result of the strabismus. So once you correct the head posture, only then the manifest of the strabismus will take place. So once you have established that yes, there's a history of strabismus, and then there is a head posture, you go in for the cover test and the other light reflex tests. Now, Hirschberg, the disclaimer is that you have to correct the head posture. So once you've corrected the head posture, you look at the light reflex, the reflex falling in the center in the 2 eyes. It's symmetrical, so it's an orthotropic patient. You see the reflex falling on one edge, that is the nasal pupillary margin in this case, so you know this is an exotropia. And you see the reflex similarly in this patient falling on the inferior pupillary margin, so you know it's a hypertropia. So the direction of the reflex will tell you the direction of the eye and then the strabismus. Again, remember you have to correct the head posture, and once you know that there is a reflex falling in one side of the eye or one side of the pupil, you can actually quantitate it on the pupillary margin, on halfway between the pupil and the limbus, and on the limbus quantitating to double on the prism bar test. So these, after you have done the Hirschberg. Now for example this one, if you can just tell me what do you think this patient has? You don't have time, so just shout it out. What do you think this patient has? So you look at the reflex, you think that reflex is nasal. So you think that the patient is having exotropia, but in fact this is not. This is an orthotropic patient. Normal reflex will also fall on the inferior and nasal pupillary margin. So if you think that there is strabismus in patients like pseudostrabismus, what you have to do next is to establish that yes, my diagnosis on Hirschberg is correct, so I have to do a cover test. So if there is no movement on the cover test, that means your diagnosis of orthotropia is correct. So if you have a squinting patient, for example this one, you see there is a right esotropia, you cover the normal eye and you see the outward movement of the other eye. So you cover this eye and you see this outward movement, so you know this patient has a right esotropia. Again, the next one, you think this is an exotropia on Hirschberg, so you cover this eye, there is an inward movement, so you know it's an exotropia. Now, this one, if you can tell me the diagnosis, because cover test will tell you a lot of other things also. So carefully look, this is a Spielman occluder, it's not a complete occluder. So it's a Spielman occluder and the eye undercover is going up. So what do you think the diagnosis is? the eye is going up, and once you remove the cover, the eye is coming down. Both the eyes are coming down, so it's a dissociated vertical deviation. So these conditions will also get manifest with the cover test. So cover test will not only tell you the movement of the eye and the strabismus, it will always also tell you things like dissociated deviations and things like maybe pseudotosis and nystagmus might be uncovered with this cover test. So now you have done the reflex test, you have taken history, and the most important thing that you have to see is the extraocular movements in every patient of strabismus. So monocular eye movements are known as ductions. So you see whether the eye is moving in, that is adduction. You move the eye out, that is abduction. Eye going down, infraduction. Eye going up is supraduction. You close one eye and you check for ductions. You denote the ductions in the form of a plus, and you grade them if you see any limitation as -1, 2, 3, 4. It's a simple maths. Every movement is divided into 90 degrees. So you see a 25-degree limitation, you call it -1. A 50-degree limitation, you call it -2. 75 and 90-degree limitation, 3 and 4 respectively. So just an example. So this is a patient who has an abduction deficit. So normal corneal reflex would be visible, and the cornea 1/3 would be covered by the limbus. If you see a little bit, 25-degree of limitation, that is -1, 50-degree, 75-degree, and the eye is not rotating past midline, that is a -4 abduction deficit. Clinically, just an example, this is primary gaze, and this is the patient looking to the left. So primary gaze, this patient cannot move the eye a little bit, -1. It's quite subjective, but yes, over time you will see that there is a consistency in your measurements yourself. So this is say -2 or 3, and this patient is not going beyond midline, so that's -4 abduction limitation. Now always check for versions in the cardinal positions, these 6 positions which will tell you the basic action of every extraocular muscle. So for adduction, in adduction you check the obliques, and in abduction you check the recti. So this is again an oblique overaction manifested, and then you mark it by a plus. So you look at the light reflex, the amount of reflex that is falling again on the pupillary margin, between the pupil and the limbus, on the limbus and beyond the limbus will tell you that this is a left inferior oblique overaction graded as 1 to 4. These movements, once you establish, then you can check that the extraocular muscles, all of them are working in place. And not only do you check the extraocular muscles, you have to confirm the ductions on the versions also. So once you see there is an abduction deficit, for example, this patient, you check in the versions, there is a persistent abduction deficit on the versions also. That means we are dealing with a case of left LR palsy in this patient. Again, this one, you think that, okay, reflex is normal in both eyes, there is no problem, but you closely see, you see this adduction and the eye is going a little up. So you know it's a inferior oblique overaction of the right eye in this patient. So subtle oblique overactions will be manifested only once you make the patient do versions and you see on adduction and abduction both. Again, extraocular movements, once you're checking, also note at the lid position also. So once this patient is having a depression and elevation deficit, but is also having a narrowing of the palpebral fissure when the patient is looking towards the right. So lid movements also have to be noted along with your extraocular movement examination. The last thing that I want to tell you is how you assess deviations by prisms. So once you have established that yes, this is the exotropia I am dealing with, this is the movement that is seen on the cover test, now I want to measure it with the help of a prism. So always place the prism perpendicular to the line of sight, that is the visual axis, because mostly in the clinics we use glass prisms. So if you have a patient like this, you always place the prism perpendicular to the patient's eye. And there are a lot of tests, but what the basic that you have to remember is that you put the apex towards the direction of deviation of the patient. So this patient is having an esotropia. Okay? So where do I put the prism? In front of the right eye, and you put the apex in or the base out. So this is how you do the alternate cover test, and you put the prism in front of the patient's eye with the apex in and gradually increase the prisms till you get a neutralization of that movement. So always give the patient something to read, accommodative target at distance and near. Don't do it with the help of a torchlight because that will be inaccurate. So once you have done it at distance, the same thing, you can do it at near. So near, again, you have the apex in because it's an esotropia. You keep on increasing the power, you keep on doing an alternate cover test till you see there is a neutralization of the movement of the eye. Now, it's important that you remember that in vertical deviation, for example, this patient is having a slight downward movement of the right eye, this flick that you see. So, this patient is having a right hypertropia. So, I put the apex up in the right eye. And the same test, you do an alternate cover test, make the patient accommodate, and keep on repeating till you see a neutralization of the movement. In large strabismus, where you want to use more prisms, so always you can use prisms in front of both eyes. Don't stack prisms on one on the other, but the direction will be same. So if you have an exotropia, you'll have in this patient you'll have a prism apex in front of apex out in front of this eye and apex out in front of the other eye as well. In paralytic strabismus, this case actually recapitulates whatever we have learned today. So you correct the head posture, then you look for the Hirschberg reflex, and you see there is an outward movement in the left eye because this is a case of esotropia. The patient is taking a face turn, so it's a left LR paresis, and then I do an alternate cover test with the help of prisms with the apex pointing inwards, and you repeat the test till you see there is no movement in the either eye. Now in paralytic strabismus, you have to remember you have to put prisms in front of either eye. In order to document the deviation and again prove that it's a paralytic squint, because deviation would be different when you put prisms in front of different eyes. Now again, horizontal and vertical prisms can be stacked, but it's always better if you put horizontal in front of one eye and vertical in front of the other eye. In children, sometimes it's difficult to do an alternate cover test with prisms, so you just keep on stacking, increasing prisms till you see the reflex is symmetrical. It's a Krimsky test. You're not doing an alternate cover, you're just increasing the prism power till you see that the reflex in both eyes is falling symmetrically. So that will give you an end point of your deviation. So I think that's about it. The last thing, maybe if we meet next year, we'll discuss the other tests. Any questions, always do a refraction in the cyclopedia, because I think it's a topic of its own. So thank you very much.